All righty, we'll begin now. My name's Emily, and I am here to introduce Joshua Faulkes. He is the cytology services manager at the Wisconsin State Lab of Hygiene, where he leads the cytology and anatomy pathology sections. A frequent CAP inspector, Josh knows the CAP general checklist better than his own children's hockey schedules. As advocate for cytology education and former cytology program director, Josh is actively working with the Wisconsin State Lab of Hygiene and the Albany College of Pharmacy and Health Science reestablished cytology training in Wisconsin through a new satellite program because the Midwest still needs cytologists. A proud member of the Wisconsin Society of Cytology since 2009, Josh served as interim president from 2019 to 2022, president from 2022 to 2024, and now serves as secretary. Under his leadership, the WSC provided education and fellowship to cytologists across the Midwest during a period of declining enrollment in neighboring states. He also serves on the American Society for Cytology's long-term planning committee and website design subcommittee. Please welcome Josh.
Thank you for that introduction. Thanks to everybody for coming today. Do we have any Appletonians in the audience today? It's just the one, so you can laugh at my quick story. I've been here, I think, one other time for an event similar to this, but I was here last weekend. I know that my bio mentioned hockey for my kids' hockey tournament, and I went to apparently there are two hockey rinks in Appleton, and I went to the wrong one. So there's two. I went to the wrong one, the Appleton Community Hockey Rink. I was supposed to go to Champions Hockey Rink, and I witnessed a car crash that happened just outside of the rink, and I stayed around to act as a witness and thought, gee, wouldn't it be crazy if I was involved in a car crash on the way to the hockey rink I was supposed to be at? And of course, there's a 3-lane roundabout. And getting to it, I was like, I have no idea what I'm doing. And I was involved in a minor fender bender. So that's my Appleton story. So I love this city. So yeah, lab updates. Mainly, I'm going to be talking about HPV self-collect and some new advances in GCCT and some other communicable disease advances or verifications, validations that have been made with our friends who are all here and can help me answer some questions about those validations that have been done over a communicable disease. And we're also here to answer any of the questions that you might have, so you know what's going on with the lab. We do this every year, or we try to help you with anything that you might want to know about what's happening over at WSLH. So, oh, technical difficulties right off the bat. Maybe it's upside down. There we go. It was. So by the end of this talk, you'll be able to appreciate the potential efficacy of self-collect HPV. So you'll know, if you don't know what it is already, what is self-collect HPV. Testing in the context of co-testing and HPV primary. So those are the two modalities that you're probably already using. Understand the mechanisms, advantages, and disadvantages of this test to better assist your patients. And then you'll have a reviewed gonorrhea, chlamydia, TB, STI collection at WSLH and learn what has changed. And you'll be reacquainted with ordering and customer service processes at WSLH Cytology and CDD. So, what is HPV self-collect? In many ways, it's very familiar. It runs on the same Roche Cobas assay that we've been running for 13 or 14 years. You'll recognize it as HPV reflex or just HPV that runs along with co-testing or HPV primary if anybody is doing that right now. It uses the same halogic thin prep preservative that you run with the PAP. So over here you can see same familiar PAP vials that you've been using for 15, 18 years at least. And this is our machine. We load it onto the machine. Those are pour-off vials. So if you're doing primary, that's the reason why primary used to cost $3 more, is because we have to pour it off into these little vials. And so that's why I have that explanatory picture, because I got asked that last time. We did normalize all of our prices to one price 2 years ago. But there are some differences with self-collect to be aware of. So this is a new option for screening. The draft USPSTF guidelines recommend HPV screening for women 30 years and older. For women under 30, PAP or co-testing is recommended, but HPV self-collect may be the only way to reach some populations. So women who refuse pelvic exam, certain cultures, women who don't want to be alone in the room with a doctor, the trans community. There's a million other individual scenarios where the opportunity to do a simple vaginal self-collect could be an advantage, where you're not going to get a screen any other way. Screening can include clinician or self-collected samples according to USPSTF now. I would put on the caveat that there are some contraindications to this test. It's not a one-size-fits-all. It's not intended to replace co-testing or HPV primary, but there are many advantages to this test. The advantage here is that you no longer need a clinician trained in pelvic exams on site for this collection. So we could open up screening to clinical sites who do not have a nurse practitioner or similar personnel. I have heard of successful sites where really you have a medical director overseeing and a medical assistant is what you have available, and they're the ones who direct the patient to a private area, make the or do the paperwork and assist with the collection. There are additional similarities with follow-up that you'll find familiar. So it's the same assay, it's a similar report. Patients with a positive result are referred to the algorithm below. So follow-up for new clinics might be a challenge, but you're probably used to seeing something similar to this. So if it's HPV negative, because the test is new and they found that it's somewhat less sensitive, not significantly, but it is slightly less sensitive because the patient's collecting it. Repeat testing in 3 years as opposed to co-testing or HPV primary, where you might remember follow-up generally for an HPV negative and an otherwise healthy patient was 5 years. Personally, something that I generally don't agree with, because that's about how long it takes for cancer to develop. So that's a false negative. There's trouble, but that's what the guidelines state, but just the same. HPV negative for a patient on a self-collect, you'd repeat HPV testing or other screening in 3 years. HPV 16 or 18, we all know the patient will go for colposcopy with collection of cytology and or of cytology and biopsies. HPV 45, so these other types, 38, 58, 31, 52, clinician collected sample for cytology and or dual stain. These are the types that show up on our current testing modality as other. And so the clinician collected sample, so this is where you would have to refer out. The patient would actually have to come back for cytology. So this is sort of the problematic result where, let's say we have a site that says, oh, great, now we can screen for HPV, and they get an other result. Now we have to send the patient away to a site that does have a nurse practitioner. Maybe the reason the patient needed to come in to our places because they didn't have transportation. So that's something that we have to think about as these tests come on board at sites where there is no NP or someone else who can do a pelvic exam. These types, negative for all other carcinogenic types, 56, 59, 66, we don't really have to worry about, but I did include them here. Repeat HPV testing in 1 year. USPSTF did throw that on there. So this is a assay that will be coming on board, hopefully in 2 months, could take longer than that. So it's important that we know and discuss the advantages and disadvantages before it's implemented. And so definitely at the end of this talk, keep this in mind because we're going to talk about other things when we get beyond HPV self-collect. But the advantages, it opens screening to locations where cervical collections are not possible. It makes screening attractive to additional populations. The disadvantages, Roche's own FDA validation showed a lower but acceptable sensitivity rate in both collection types, and I'll get to both collection types. There are 2 devices that were validated compared to HPV primary, which makes sense, right? A clinician, a trained NP, or a doctor collecting it compared to anybody off the street collecting their own vaginal sample, which isn't the ideal sample in the first case, is going to be slightly less sensitive than the sample collected by a trained medical professional. The Evelyn brush, which is one of the 2 collection types, slightly outperformed the Faulkes swab in sensitivity and unsatisfactory rates. And I would say that the unsatisfactory rate contributed to this slight, very slight drop in sensitivity. In the end, it was validated. These slight drops in sensitivity were insignificant enough for the FDA to consider this a valid test. Valid as saying that it is clinically similar to clinically collected samples. And this is still an HPV screen. It has the same issues with specificity as all HPV genotype tests. It's not a useful screening tool in young and at-risk groups without additional testing. So we're still looking at women who are younger than 25. You're not going to test them for HPV to screen for cervical cancer because lots of women under 25 have HPV. It doesn't mean that they're going to get cervical cancer. You're probably not going to test women over 25 who have other risk factors just with HPV. You're probably going to look towards co-testing for groups who have previous abnormal results, who have immunosuppressed conditions, who have other risk factors. And yes, all of my headers were references to, if you were a fan of early aughts, alternative rock or punk, the long winters, and let's hope that it's not a long winter. There's also a line in this album, I like the old days, but not all the old days, just the good old days. And so that's in reference to when I'm talking about co-testing, HPV and co-testing. There's been several studies showing that together those 2 tests, HPV, whether it's primary or as a reflex, or even self-collect, if you account for that small loss in sensitivity, is still a better test on its own, although more expensive than HPV alone. If the goal is just to detect CIN2+. My own lab just published a poster that actually won best presentation by a cytologist that saw we were comparing several clinics that had moved to HPV primary. This is where not many of the clinics here are doing HPV primary. This is where women over 25 are just screened with HPV. And then if it's positive, we perform a PAP afterwards, as opposed to what most folks do where you perform a PAP, and then if it's ascus, you might perform HPV to clarify that result. These clinics are doing essentially an reverse algorithm. We compared co-testing samples to primary samples and found that in the co-testing cohort, around 4.4% of HSILs would have been missed had we applied the primary algorithm. So in a high-risk population, you end up missing a decent amount of high-grade disease, CIN2+ disease. So that's why I mentioned that in a healthy population, the HPV primary algorithm is great. It's an excellent screen. But when you add in factors where the patient's at risk, the ASCCP or the USPSTF guidelines don't really apply to them because of other outside factors, other screens need to be added to assure security for the patient. So, having said that, you have a patient who's healthy, you want to do self-collect. When can I do it? Verification of this test, and this slide is modified, but it's older, so many of you have already seen part of this. Except I will point out that the estimated 1 to 2 month project, that has stayed the same, but I'm just saying it again 3 or 4 months later. So we started this project quite a long time ago, a year and a half ago, with Penn State, but that was before the FDA approved it. So we were going to validate this ourselves with the help of Penn State. But then the FDA and Roche validated these 2 collection devices, the Evelyn brush and the Copan flock swab, on their own. So thanks to Roche for that. And now all we have to do is verify it. So verifying an already FDA approved test, a lot easier than validating a test yourself. And so even though I should mention the LDT rule was, the kibosh was put on that, so it is much easier for us to do our own LDTs. But regardless, we don't have to do that. And many thanks to Health First and Eau Claire County for assisting with this project. The Evelyn brush, we only need about 5 to 10 dual collections. Copan, we need 20 to 40 probably dual collection samples to finish the project. I know that Eau Claire I think is just getting started. Is that right? I don't know. In any case, worst case scenario, I think we'll be running this test on one of the swabs in 2 to 6 months. I think that's worst case. And so the important thing here is education, dissemination. I'm very glad that HCET was able to squeeze me into this schedule so that people can watch this talk, let each other know, and clinicians are aware of the test's advantages and disadvantages, and that we can get the word out, because I know that there are lots of federally qualified health centers, folks that work in DOC, university healthcare centers that could benefit from having something like this. So how do I order HPV self-collect if I'm interested in doing this through the State Lab of Hygiene? So an important thing to point out here is this is a totally separate kit. So I mentioned there are parallels and there are vast differences, and this is one of the vast differences between your conventional thin prep PAP / HPV and HPV self-collect. You cannot perform a PAP on a thin prep vial that's coming in for self-collect. That vaginal swab is not at all FDA approved to be put through the thin prep PAP machine. If I get caught running pap smears on a vaginally collected Evelyn brush swab, they will lock me up and throw away the key. As much as I'd like to run a study on that, because I think that's fascinating, it's a big old no-no. So these kits will be built and clearly labeled, stickerized. That is all being worked on. It'll be a separate kit from your PAP and your HPV primary kits. And how do I order it? The usual way that you order all of your kits through CDD for cytology, pathology. The information is down here. If you want to get your phones out, take a picture. Our website hasn't changed in years, although I think we are going through a major rebuild, so it'll be even better in the coming months. But this a terribly long email that needs to be fixed, but HM specimen receiving clinical order staff at slh.wis.edu. It's almost as bad as my joshua.faulkes at yes. So, but our customer service number also is toll free and works just fine. But yeah, I should point that out. New kit. So you're going to want a separate stash of self-collect kits for these healthy patients who otherwise you for one reason or the other don't want to collect a PAP or perform HPV primary on. And then on the rec, very clearly demarcated HPV primary screening. This is just a draft, but it will look something like this, where you will have under HPV primary, because technically this is an HPV primary test. You'll have HPV self-collect, no PAP reflex. You will not ever get a PAP out of this unless, well, I'll leave it at that. You'll never get a PAP out of this for now. And besides, it'll be a vaginal collection. There's not too much that I can do with those cells outside of maybe a study someday. So, but yes, so under HPV primary screening protocol, there's HPV self-collect. It may end up getting its own section. We'll see. But it'll have its own orderable. Another neat thing that I didn't mention, but it was on the slide, is that it's the same ICD-10 code as your usual PAP reflex. I'm sorry, HPV reflex. It's the same ICD-10 code as HPV primary. It's the same ICD-10 code as any HPV test. It's the same test, same assay, same cost. So how is it collected? That's another interesting question. And thanks again, after looking at this, to all the folks that are helping us run this verification. Because even though you don't necessarily need an NP helping with this, after looking at this graphic for a little while, you may think that a bachelor's degree or higher degree may help. It is somewhat involved, so the patient is instructed to wash their hands. You escort them to a private room and give them these instructions. And so this is the more complicated, actually, of the two devices. The Evelyn brush, actually also the more intimidating of the two. The Evelyn brush is roughly the size of maybe a tampon. And they remove the brush from the case, and then remove that from its protective casing, insert the device into the vaginal canal, and then the brush is actually taken out of the plunger in step 6 and rotated 5 times. And then the protective case is actually put back over it and then placed back into the swab. This is actually not what's mailed. Those cells are on the brush. So in the next graphic, you can see that the cells are exfoliated from the brush. So the exfoliated cells from the vaginal canal are then exfoliated into a thin prep vial. So they're now pickled and they will be perfectly fine for up to, I believe, 6 weeks. So you have plenty of time to get it to the lab. It doesn't need to be put on cold pack like some of our other samples. Everything, that's why I love pathology. We keep banker's hours because everything's on alcohol. And we We work fast when it comes in, but we don't have to worry about it unless it's -30 or something like that outside. Nothing is going to get ruined. So yeah, so the cells are expressed into the thin prep vial, and then we do worry about leaking samples though. So I don't know if many people know this, but there is a little line on thin prep vials that you tighten it down to. So. So billing and costs, I mentioned this already before, but all HPV screening, reflex, primary, and when this test comes out, should stick, at least for this year, to the list price of $71, slightly higher than the federal Medicaid rate because it's against the law to undercut the Fed. It's the only reason why it's that cost. DPA, Department of Health and Tribal Health patients without insurance would be eligible for basic agreement funds. Everybody uses different words for that. The DPH pot o' money, the fee exempt, and so on. But yes, so it's the same CPT code, so it should go run through the billing system similarly when it comes through. If you expect a significant volume, though, more than a handful of folks a month, please reach out to me and or your DHS RHFP program. Ashley is in the room with us because we have no idea. We have no idea what the demand for this test will be. So if you're thinking lots of people will need or want this, lots of clinicians will push for this, we'd like to know. Just a reminder that WSLH really doesn't have the capacity to bill patients. This is really more for a different crowd. I don't think anybody here is sending bills to patients, but we can bill locations if that's necessary. So to get started, if you're not already a WSLH client, you can reach out to me and onboard as a WSLH client. Obtain a billing ID number, requisitions, collection kits. This is also probably not for the HCET crowd. You're probably already dealing with us. And we'll get you in touch with WSLH clinical supplies, get you in touch with the excellent staff over at specimen receiving and clinical orders. They are the best. So taking a brief pause before I get into the advances over at CDD, just to reiterate, self-collect 2 months at the earliest, hopefully before summer. This test will come out. It's really not a catch-all test, something that, we would like to see replace primary because it's easy, because it is slightly less sensitive. On the other hand, if you have patients who would benefit from it, it's great to be able to tell a patient who is very uncomfortable with the prospect of a pelvic exam for whatever reason. It is something that you can add to your tool belt to increase coverage of HPV screening. So more good news coming out of the communicable disease division, testing update. Oh. There we go. A number of verifications, right? Or full validations, one verification, one validation. Verifications. So for trichomonas self-collection, we have patient-collected vaginal swabs are now approved for use at the state lab, and at the end of this, there is a summary graphic. Self-collected specimens can increase patient satisfaction and may expand those who are willing to be tested. There's no change to workflow in this case. You can use the same collection kit, the orange multi-test swab kit. It's the same price, same ordering process, same reporting. And so it's the first of these two. So this is the validation. Yes. And so with chlamydia and gonorrhea, we have validation for pediatric collections. So all ages can now be tested on all of your favorite collection kits. And so then there's specifics in the following table. So a new collection kit has been added for pediatric 14 years and under patients only. The unisex or white kit for throat or rectal testing. Also, no changes to your workflows, same price, same ordering process, same reporting. And just an asterisk here, this is intended for treatment only, cannot be used for medical legal investigations, and continue to use cultures for this purpose. And so just to sort of summarize these changes, we have this handout. This is on our website, correct? Oh, great. And so Alana just indicated for those who are online, although you can't get the handout here, it is available at the front, the conference front desk table. And so you have the familiar orange kit, and we have a new patient collected vaginal swab, CT and GC, actually across the board, Trick and MGen 14 and up. And then the white swab, also the added 14 and up. And is this new, or has this always been here for the urine? We've always had 14 and up for urine collection. Okay, I did not know that. So yes, which is great. I assume this would be wildly well received. But yeah, and so lots of effort goes into, I know, even just a simple verification for those of you who aren't too much into lab. Verifying essentially just means checking on a manufacturer's validation, and validation takes lots of work. So very glad to see this coming out of communicable disease. So I think these are some of the references for a few of the more controversial points that I made regarding co-testing versus primary. There's still a lot of study to be done regarding self-collect, even though the test is validated by the FDA. It's brand new. And it also brings up the point of at-home collection, which was also recently validated. There's one collection method. It's very proprietary, so it's not realistic for WSLH. It's one company. The name is escaping me at the moment. It's very kitschy, so I should have remembered it. But essentially, you have to have your clinician order it, and then the company mails you the collection kit to your house, and then you mail it back to the company, and the testing is only performed at that lab. However, the rumor is that Roche is working on a similar device, which it could easily validate, because really all that the clinician is doing at the clinic is walking you to a private room. The hard part is the mailing, how stable either are the cells in the collection device, or how much do you trust the patient to exfoliate the cells into the pickling juice for mailing. And so I know that Roche is working on a home collection kit as well that could be available to labs in a year, 2 years, 3 years. And so that's something to think about as well. I feel like that is something that DHS could easily coordinate. A nurse could interview a patient, ask them when was the last time they had their HPV screening. If the answer is 5 years plus, it's time for your HPV screening. WSLH will mail you a kit. So that's also something to think about. So thank you. Hopefully it's not a long winter and we have something like this to look forward to. I don't know if I ran long or very short. Very short. So, but these are all the lab updates we have. I knew I wanted to save some time for Q&A. So if we don't, I've gifted you 25 minutes. Yes, wonderful.
Thank you. Thank you.
Thanks. Question, is there a reason we would do a self-collect swab for trick over the urine? Alana?
I think for a lot of the similar reasons that Josh mentioned here, that there are certain patients that you might not be able to test unless there's a self-collect option, ones that would potentially be adverse to getting a pelvic exam. But urine is fast and it's easy. So I think it's certainly nice to be able to do multiple types of collections here. Vaginal swabs can be a little bit better for chlamydia, gonorrhea, and trick than a urine. It's not a huge difference for these specific diseases. A little bit different. I mean, cervical sample I think is going to be best for HPV, while a vaginal sample can be better for some of our other STDs. But it's another option. So sometimes we're having like these get yourself tested events, or people just want to go into a room. Sometimes people aren't able to produce the urine that they need in the moment they need to. So there's a couple of different options. This one was FDA approved, so we wanted to add it to our menu.
Okay, next question. To confirm, the state lab can now test 14-year-olds. I sent a sample in a year ago and it was declined due to the patient was 14. And I also put in the chat for those of you online the letter that's on the state lab website so they can see the information about that.
Yeah, I just want to say we are super excited to be able to offer this. I know you guys have been asking for it for a very long time. We went live on Tuesday. So it was like fresh off the presses. Last year I spoke about this, that the FDA was trying to prevent us from doing these kinds of lab developed tests. And with the courts overruling that as quickly as we could, we got that finished and it's active and live now. So if the FDA changes their mind, they can't take it back if we're already live with the test. I just got to say that. But yes, 14 and under for chlamydia and gonorrhea on clinician collected samples. There's no self-collect for the pediatric.
Can an RN count as a clinician for oral swab collecting for chlamydia and gonorrhea?
A trained nurse, yeah. I think that a medical provider who is trained in the collection is acceptable for these. We don't say, you know, a doctor collected. If you have the right training and background, just like when we have COVID tests, we wanted to have a provider. You would have, you know, trained National Guardsmen, but as long as they've received the appropriate medical training to do that collection, then it can be considered clinician collected.
Hello, my name is Ashley Domberwicki. I am the nurse consultant with the Reproductive Health and Family Planning Unit. It is within a nurse's scope of practice. So that's really what you're looking for and looking at. Our unit does provide nurse protocols. So as long as that medical director signs off stating, yes, you can do these things, then there is really no reason you cannot be the one collecting them. I think it just gets sticky in certain situations where there are medical providers who may not be as familiar with certain practices and get nervous with letting the nurse work up to their full scope and potential. But in reality, there's no reason they cannot. I think I said that.
Just as like a follow-up off of what you were just saying, do you have like example protocols or is like stuff, like anything you'd be willing to share for like a medical director to be able to sign off on, like something we could kind of go off of?
The RHFP RN protocols, that's the title of it, is available on the DHS library for anybody to view it as public record. We go out and have them approved throughout the entire DHS process, which is what takes so long in getting our new ones out that I'm currently working on. The biggest thing, it just tends to be guidance on it that can get sticky for us. Just as like we don't work directly with every single clinic that's out there in the state. We have specific ones, but they are available to find on DHS's homepage, find their library, and you should be able to find our entire protocol handbook. It's the RHFP RN protocols.
I can also make sure that Adele had, send that out to the folks, and I can try to chat, find it myself right.
I just wanted to add that there might be additional training necessary for the pediatric collection. And that was the same for COVID as well. I mean, I think you need to have training if you're working with like a 3-year-old to do these kinds of collections. That's going to be something extra. Doesn't mean a nurse can't do it. Just make sure you have the right training before you go for it.
Any other in-person? What is the expiration dates like for the HPV self-collection swabs? You know, will they be good for a year, 6 months?
That's a good question. I believe that the Evelyn brushes last 3 years, and the Copan swabs are similar to bacterial vaginal collection swabs. So, do you all know? Is it like 3 to 4? 2? Yeah. Yeah. So they're similar to culture swabs. So I think it's 2-ish. So, and thin preps are also similar to that anyway, right? Because you all have thin preps on, and we usually replace those every couple of years. So.
You mentioned the Evelyn brushes and that there's a second kind. Is WSLH going to offer both, or are they just going to primarily use the Evelyn brushes?
That is a good question as well. We're probably going to stick to one, but we are going to verify both because there's supply chain issue worries, of course, after COVID. After both tracks are complete, we're going to have a discussion with Eau Claire County, who's helping us in Health First, and get feedback and discuss which device the patients seem to gravitate towards the most. Right now, it seems like the Copan flock swab is what patients prefer. It's less intimidating. The instructions are slightly less difficult to follow. And it actually turns out that the Copan flock swab's less expensive. So that's kind of a win for everybody. So yeah, but we're going to verify both of them. You know, if Copan goes out of business, it's rough for Roche, but we'll still have one more device to fall back on.
I was wondering if the HPV self-collect and similar self-collection devices you've been discussing can be used in an outreach setting.
That is another great question. So the definition that's provided by Roche for their validation is it has to be collected in a clinical health setting. So yes, as defined by a medical director. So you could set up at a university if the medical director at UHS said, we're going to hold, I don't know, a get yourself tested event at 333 East Campus Mall. You could provide self-collect samples and, you know, cordon off an area with sheets, provide privacy, and have students self-collect. The comment was if a church was having a health fair. If they, yeah, so a nurse is telling me who knows more about it than I do. If they set up an appropriate area, that's a clinical setting. Yeah. I've had a few discussions with this, and the ingredients that I've most often interacted with is the medical director needs to say that it's okay. There needs to be medical personnel and a private area for the patient. The medical personnel that's approved by the medical director is the one that needs to direct them to the patient to a private area, provide the instructions, and then everything is kosher.
Check if we have any online.
No question.
All right, any other questions?
Now that we've finished the project with pediatric CTGC testing, we are working on pediatric trick testing as well. That'll be coming in probably a few months. We have samples in-house to complete that validation.
Any other questions? And for those online, they did open it up just to state lab questions in general as well.
And I guess one more thing to wrap things up is that the cytotechnology school technically now is open again. If you know anybody who is interested in cytology and for whatever reason wanted to look into it but couldn't last year or 2 years ago because of the closure by CALS, we run through the College of Pharmacy and Health Science through Albany, New York. Students take their master's coursework through Albany, but they can attend at Madison at the State Laboratory of Hygiene. So they take our practicum, but Albany's didactic. We've had our first in-house pilot student, and we've had a few residents. So in their senior year, resident students, I did, sorry for the people who are online, I did quotes. They're not technically clinical residents, they're not doctors, but they do rotate through on a clinical rotation in their senior year if they so choose, and do real clinical work at the state lab during their last 3 or 4 months. So we had one true pilot student who will be with us for all 3 years, and then a few who have rotated through. So thankfully, Jenna LeBlanc, who's the program director over there, and actually Nebraska, which also would have been a great partner, but we ended up going with Albany, reached out so we could continue to train students locally. So hopefully there won't be a shortage of cytotechs in the upper Midwest. It's us and Mayo are continuing to train cytotechs, and we do assist in some ways with residency. So